Thank you so much, everybody, for reconvening. And this is our opportunity just to get some quick feedback from the 4 workshops. Obviously, there's a lot more depth in the individual workshops themselves, but each workshop was asked just to capture 3 key messages, if possible, at the end. But the write-up from the whole workshop will be fed into the developments that we've been talking about. But so in no particular order, I'm starting from my left. I'm going to ask Jackie to start off the feedback. Thank you.
Well, we had a vast and far-ranging discussion about metrics, particularly with reference to the quality standards for complex pathways, long-term conditions. We spoke at length about COPD and heart failure, and that raised points about the need to perhaps present data in a way that would be useful for patients to get a sense of how strong the pathways are in the areas that are served by them. So challenges there in terms of the nature of the data and how to present it most usefully. There were questions about who takes accountability when metrics are presented, who's actually accountable for translating the findings into action on the ground when it's across a whole pathway. So when people generate the information themselves, they can translate that into action. When it comes from an alternative organisation, who is responsible? And then there were issues that perhaps we've used data for a long time in prescribing, for example, for clinicians, but linking prescribing data with outcomes across pathways is a useful approach. So integrating data sets to actually be able to see the different processes that lead to the outcomes is really valuable, but does raise questions as to who would actually commission or provide such metrics.
Thank you, Jackie. What we'll do at the end is just check if anybody's got any additional points that they want to make. But thank you, Jackie. We'll maybe move on to John.
So we were the role of public and patient leadership in promoting and driving improvements. The 3 points are, firstly, the key to much of the improvement is improving the quality of consultations. And we discussed that at some length, but crucially involves both improving the professional's ability to consult in this new world with all this information, but also the patient's ability to consult. And therefore you're moving more towards a social and psychological model of the consultation than a technological model, which is to some extent the evidence-based approach. So there's a tension there, but we didn't think it was inconsistent, and it was one of the processes that the HSN and the Best Practice Partnership could start to do some useful work in. The second was that there was lots and lots and lots of examples of good patient and public involvement and engagement banded about the room. And one of the things that can be done very simply is to share that on the patch so that people knew what each other was doing and could learn from one another. And that is both the professionals responsible for it, but possibly also the patients and public involved in those processes so they can give each other ideas, nice and simple. And finally, there was a long discussion about the context-specific nature of some of these processes. So some of these processes work really well in one place. You try and transfer them to another place that don't work particularly well. And it was suggested that actually, in order to make some of these models transferable, what you required was skilled facilitation. And again, one of the potential roles of the Best Practice Partnership would be to provide that facilitation so that something that's successful has worked in, say, Newcastle, could be transferred to Teesside successfully or vice versa.
Thank you, John. Simon?
So we were talking about clinical leadership to facilitate evidence-based healthcare, and actually it carries on very nicely from that, obviously. One of the things we talked about was the barrier, the real and the cultural barrier around time, and just the massive amount of guidelines that are out there, massive amount of evidence that we've got to try and assimilate, and how on earth anybody, a member of the public, can try and assimilate to what's right for them without just listening to the car salesman of a healthcare professional is challenging, and quite often there's not evidence, and we're interpreting. So we need to think very differently about that. And we did come across some things where we could think about doing things differently in terms of giving people information they can read before they come in, or in between appointments or whatever else to think it through. We had a bit of a conversation about, we've got 4, I'm afraid. It was always going to happen. Asked me to. Leaders and leadership, and what we really mean by that, and the importance of informal leadership as well as the heads of whoever, and also about fellowship and how it is for us to actually implement stuff, because it came from Newcastle. We don't want to do that. It's different up there and all that, and how we get around that, because that is a real barrier. Our big thing was really about having better information out there, better information for clinicians, and this goes right up to journal level, published stuff that we can actually understand, that summarises in if you treat 100 people, is what will happen. But actually, as clinicians within our leaflets or whatever else, for people to be able to understand as well, so that we can all become part of the conversation rather than subject to it. Linking it across a lot about how we do things with the person rather than to them. So not your doctor advised you to be on this, but these are the options, have a decision what's right for you. And what we really felt potential for the best practice partnership would be to, and it was similar I think to some things this morning, but would be to focus on 2 or 3 or 4 particular areas and exemplar it. Local trust, local organisations have got to do everything. We know that. But actually, you have a role in really showing how it could be, demonstrating impact, helping people learn from the principles so that we can kind of roll and roll and roll and roll. Because you can't do everything. They have to. And so let's get the mixture of those 2 things going.
Okay.
Thank you.
Thank you. Thank you, Simon. And Stephen, for...
Yep, we looked at implementation science and what theories around behaviour change can add to implementation science. So we looked at one particular framework called the behaviour change wheel, and essentially that is a well, you can't see it, so I won't try to describe it in detail, but basically it's a wheel with an inner layer that consists of motivation to change, opportunity to change, capability to change, and how those kind of different aspects can be influenced by, for example, policy, such as legislation, regulation, how some of the strategies that you might use to influence behaviour change, such as incentivisation, coercion, like that one, training. So several different components make up the wheel, its inner wheel, its outer wheel, and we undertook we worked in groups to look at an example of implementation and how this framework might apply. And the kind of issues that came out was that it was a useful framework to look at how behaviour change can successfully affect implementation, and in particular it can be used quite generically across different groups. So it could apply to clinicians, it could apply to the patients, public, members of the public, it could apply looking at the IT boards and what they might need to do to change within an organisation. So we kind of felt it has some use in looking at the whole range of how people might change and what their behaviours might need to change and how we might influence them. Second issue was, having said that, it's quite complex because there's a tendency to look at all the different factors, all the different components, and then you might get confused in complexity. So there's an issue about how you look at which combinations are likely to have the highest impact to achieve the behaviour change you're looking for, and how you might assess the relevance of the different factors. Am I making sense? Hopefully. And then the third point to feedback was essentially defining whose behaviour you are trying to change when you're looking at some implementation project. So basically, I think that was our group's feedback.
Thank you. Thank you very much, Stephen. So can I just take an opportunity before we just move on from this and close, just to see whether anybody, we've still got our wonderful roving microphones, so if anybody's just got something that they felt we've not picked up, and key message we've not picked up, or just anything you're burning to say that you just want to add from the workshops this afternoon, we can just take 1 or 2 points before we close. I'm doing that, you know that thing where they say, if you stand long enough, somebody... No, I'll do it. You can tell I've done my teacher training. But no, I think that's probably a reflection, actually, of the fantastic feedback that our scribes and facilitators have done, because they've obviously captured the key messages there. And I hope people had... it sounds like we've had some very fruitful workshops. And as I mentioned before, the detail will feed in as well as the high-level summary. So really important. So thank you very much for that. Thank you to our workshop facilitators.